So I don't have any conflict of interest. Coming to the malaria, this is our strategy. Means this is our worldwide, not our Pakistan strategy, but worldwide strategy to end up the malaria. So, yes, as Dr. Ali said, malaria is an important thing, but usually we overtreat it. So, when to suspect malaria? In endemic countries, if the patient is having fever more than 37.5 and no any other obvious cause, means it's very important, no other any obvious cause or clinical symptoms, then you should assume this is malaria and go for the testing. The sign and symptoms are very non-specific, so you don't patient don't have any other thing other than fever. And if you treat on just on the clinical basis, you will overtreat it. Most of the time. So coming to the complicated malaria is the severe form of malaria and which is caused by the progression of infection, which is not treated timely and not properly treated, and usually caused by the falciparum, but Vivex and Novelty can also cause the complicated malaria. The risk increases if the uncomplicated treatment delayed, and complicated malaria can be fatal or life-threatening. So complicated malaria can be defined by the two components, clinical and laboratory component. So clinical, if you have one or more of the clinical or laboratory criteria, then you can label it complicated malaria if there is no any other cause of fever identified and there is parasitemia on the testing. So if the patient is unconscious in kids less than 3 GCS, there is prostration, multiple convulsions. In cerebral malaria, usually patients have frequent convulsions, frequent seizures. If the patient is having acidosis, if hypoglycemia, so bacterial meningitis or any other form means encephalitis usually doesn't cause hypoglycemia, but cerebral malaria or complicated malaria does. And severe anemia, if the HB is less than 5 gram per deciliter, if there is renal impairment, if there is jaundice, if there is pulmonary edema, which can be manifested by the clinically or as well as the laboratory, and significant bleeding from anywhere, nose, mouth, rectally, and there is shock, compensated or decompensated shock. Most important is the parasitemia. If there is more than 10% or more than 500,000 per microliter parasite load, then it will be called as complicated malaria. So Vivex malaria and Novelty can also cause the complicated malaria, but criteria will be a little bit different. In case of the Vivex malaria, there is no threshold for the density, for the parasitemia. But in Novelty, there are two criteria. If there is a high parasite load, more than 100,000 per microliter, which was 500,000 in the falciparum. And second criteria is the patient is having jaundice and more than 20,000 per microliter parasite load. Then you will label it as complicated malaria caused by the Novelty or Vivex. So coming to the diagnosis, the complicated malaria or severe malaria is a medical emergency. But detailed examination and history is very important to rule out other causes of fever and increased GCS. So unconscious patients should undergo LP, which is very important to exclude the bacterial meningitis. What tests do we have? We have microscopy, antigen detection by the RDTs, serology testing, and molecular diagnosis. So any idea what is the gold standard test? Thick and thin smears, microscopy is the gold standard test. Thick smear will tell you this is malaria, and thin smear will tell you what species is causing the malaria. And a microscopy gives you diagnosis, and it will also gives you very important parameter, which is the parasitemic load, which is very important, and it's a prognostic indicator. In general, the heavier the parasitemia, the sicker the patient, but asymptomatic patient can have high parasitemia or severe, means severely manifestations can present with a low density infection. It can happen with any parasitemic load. So second modality of testing is the antigen detection, which is done usually by the RDTs, that is the rapid diagnostic test. It is the alternative of microscopy, and it will tell you the antigen or the enzymes, which is specific for the different species. And various kits are available. Common are the disc or cassettes, and it will give you very immediate result in 2 to 15 minutes. Means you don't have to wait, and it can have, means you can done on your bedside, on in clinic, or means within few minutes you can do it. So RDTs are useful alternative of microscopy in situation where microscopic examination or microscopic diagnostic is not available. And it can be done in clinical settings, and different programs do RDTs. So this is the image which I took from the WHO guidelines, and this is a commonly used RDT, which will tell you different species with the certain, means mixed infection too, and especially PFHRP2 gene is very important, and you can't diagnose it with the microscopy. If the patient has taken treatment previously or patient was incompletely treated, patient's microscopy will be negative. So in that case, RDT will be very helpful, and especially the PFPHRP2 gene. So what should be done if the microscopic examination is negative? It should be repeated. It should be repeated after every 6 to 12 hours, at least 3 sets, or RDT should be done. If both tests are negative, means 3 sets of microscopic examination or RDTD, both are negative, then it's not malaria. Look for the other causes and treat for the other causes. If the RDT is very helpful, why are we not using RDT? Means there must be something which because of that microscopy is still gold standard. So it doesn't means few RDTs detects only falciparum, and few RDTs detects mixed infection. Few RDTs detects only Vivex or Novelci, and very, means data is not available means for the oval and malaria. So we can't say कि RDT अगर हम करेंगे, then we got to know के means what it is it malaria or is it what it is species it is. And RDT may not be useful to detect the infection with the lower number of malarial parasites. If the microscopic examination is done by the competent examiner and good lab, then it will give you a great results. But if it's done by means in not in good hands, then you can, it will be negative. Most probably it's negative. So and as such as microscopy, RDT may also be negative in case of the lower number of parasites. In addition, microscopy is needed to quantify the parasite load, which will not RDT can't give you the number of or the load of parasite. And it's the only microscopy which will give you the parasitemic load. Serology. Third modality is the serology. Serology is very important, but serology is not usually it's used for the past exposure. It will not give you results in the acute infection. So antibody detection is useful for the screening of blood donors, for the testing of the patient from the endemic area, especially the tropical splenomegaly syndrome, and the testing of a patient who has been recently treated for the malaria and diagnosis is not established yet. Means malaria is also negative and patient is having diagnostic dilemma. Then it will be helpful. Fourth one is the molecular diagnosis. Microscopy and rapid diagnostic tests are primary choices, but neither can give you a low parasitamic load. Molecular testing can give you as low as 1 parasite per microliter, but WHO doesn't recommend it for the testing purpose. It's currently it's just used for the research purpose. And other than that, we should have supportive testing for the complicated malaria, which will include CBC, low hemoglobin, RFT, which will give us the result of creatinine, which will be high, LFT, Twentus, and along with that, we should have ABGs, which will give you the acidosis. So, and along with this, you should also think about other things if you don't have malaria testing positive. Means, is it really malaria? It can be other thing. In a patient with a severely ill, means, or the patient who is sick, having sepsis, having septicemia, having having septic shock, your DDs should be broad. You should think broadly to cover everything. And in certain conditions, if the patient is young, you should treat with the antibiotics along with the diagnosis and treatment of malaria because it usually co-infects with the other things. So you should give antibiotic, but before that, you should take blood culture to diagnose any other infection, which is a very wise decision. And it will not give you a hard time if you do it initially. Otherwise, the blood culture will be negative. So these are the references for the presentation. Thank you.